But for today, I would love to introduce our speakers, Beth Meyerson and Danielle Russell. They are a cross competition collaboration here, ASU, U of A. If they can get along, you know we all can, right? Beth is a research professor in family and community medicine at the School of Medicine at University of Arizona. She is also associated with the Southwest Institute for Research on Women at U of A. Her research focuses on public health practice and research. So she has 30 years really truly walking the walk on community-based participatory research with equal expertise in both domains. Her general, right there with you, yeah. Equal kind of expertise in both public health practice and academic affiliated research and training in the general areas of harm reduction and sexual health. I found this fascinating in looking at your CV. This is a new one on me. So Beth has both a Master's of Divinity with training both at Harvard Divinity School and the University of Indiana, right? Did I get that right? And then followed that
Christian Theological Seminary.
Christian Theological Seminary in Indiana. And then the PhD in Public Policy Analysis and Administration. So she's bringing a lot of, yes. Yay. Right. A sign of a good friend right there. So a lot of different perspectives and experience being brought together. She was previously at Indiana University on the faculty as research faculty there, again, engaging with all of these different perspectives, as well as being from 1998 to 2011, the president and CEO of Policy Research Group, LLC, which was a public health consulting firm that she ran, and spent some years as the chief of the Bureau of STD and HIV prevention for the Missouri Department of Health. So really looking at—
Damn, you dug it up.
I did, right? So I was really fascinated by this. Also want to give a huge shout out to Danielle, the other speaker today, who is basically a Beth in training, as far as I can tell. Right, and is already as a doctoral candidate in in justice and social inquiry in the School of Social Transformation at ASU, is also bringing together expertise in community-based participatory research, policy advocacy, and working directly with community groups. She is also the executive director of Phoenix Community Consulting, and has a very noticeable, rich, in addition to her academic publications, which you're going to hear about today, and her policymaking expertise, has also been really vocal about communicating through public channels, right? And advocating in the public domain and sphere for harm reduction with a strong focus on the evidence base for its efficacy. So with that, I'm not going to take up any more of your time, but I'll just go ahead and hand it off to us to tell us about this cutting edge research.
Well, we are so happy to be here. Can everybody see the slide? Great. Thank you so much for the invitation. It's just lovely. Greetings and thank you again for this invitation, and feel free to interrupt all throughout. We'll take a moment to introduce ourselves just briefly on conflicts for the CME and et cetera for you guys, provide an overview of our harm reduction research laboratory, and then we'll focus on the study at hand. We'll take some time for discussion and a question really to all of us as we work together. But we'll remind you here that the citation is an open access publication, so there's no paywall, and let me know as people join, and we'll continue to repeat that citation in the chat because I know they won't be able to see something. Another housekeeping, I cannot walk and chew gum, so if there are things in the chat, please shout out and let me know. Danielle.
Oh, wait, did you just say Danielle?
Yep.
Oh, I'm sorry, I didn't even catch that. Yeah, so I'm Danielle. Thank you for that introduction, Michelle. Yes, I'm very vocal. Anywhere I can get a platform to talk about, drug user health and health equity, and like mutual aid and harm reduction, I am definitely, using my voice as much as I can, because there's, as you'll see with this manuscript in the study, there's a lot of room for positive change. So I don't think I need to add much more of an introduction. Beth, and then Beth, did you want to say anything more about yourself? We don't have any conflicts to declare, and our funding is listed here. So,
That's fine. Absolutely. Thank you.
Okay.
So what you see here is really the current work of our harm reduction research lab. We're a translational lab with working on evidence to build the scaffolding essentially for policy and practice improvement, and mostly in Arizona focus. Prior to, as Lonnie mentioned, I was in Indiana, in the university as a professor there, but I had been very focused on developing local evidence because our work in the policy process required it. Our policymaking colleagues really need things in the local area. So you can see a broad array of studies here. Their investigators hail from 5 different universities, so IU, ASU, U of A, North Carolina, and Kentucky. We have 12 disciplines, and we include community researchers, doctoral students, postdocs, junior and senior faculty members on these studies. Our work is focused on the health of people who use drugs, specifically on the reduction of opioid overdoses, bloodborne illnesses, and skin and soft tissue infections, but we seek to inform policy and practice in the systems of pharmacy and medicine. And we'll be focusing on the top right area of MAPI. But of course, if you have any other questions about studies that we're doing, we're happy to talk about that. With this, we also seek to advance harm reduction science. So you can see a latent class over to the left with our FarmNet studies. This is as we try to essentially advance the field by identifying precision orientation targets, so that as we build and test interventions, we actually know the audience that might benefit from that, and the levers have changed there. Danielle is very involved in the second element, which is the science of engagement, so that we can advance essentially the field of community engagement in research. That's another adjunct area here. The work is informed so far in Arizona, the syringe legislation that decriminalized syringes. We've been pleased for that. Medicaid hepatitis C policy. And also Danielle has brought our mood study findings to the National Academy of Science, Engineering, Medicine, and the Office of National Drug Control Policy. So we're really pleased to have hearing in policy settings as well. Danielle.
Yeah, so almost all studies in the Harm Reduction Research Lab are CBPAR oriented, so community-based participatory and action research. So many acronyms, it's a mouthful. And that's meaning that the need for these studies emerged in the community or in extant community relationships. So we don't develop a study in the lab and then pitch it to the community. We identify the need and collaboratively develop the study. And you'll see a bit of this in our description of the study and process today. A few of our values in practice include building community capacity to enact research to advance community identified goals, power sharing among and between research entities, so universities, government agencies, NGOs, foundations, and communities or community coalitions. And I think it's important to just remember that like the university isn't the only research entity. And Beth and I have been having some interesting conversations around what community is and like who the community is. And then also we co-created translation of findings to inform policy, practice, and research. Go to the next slide.
So today we're going to share findings from one part of our MAPI study, and MAPI stands for Mood Access Policy Impact. And I'll talk about various things associated with that, and Danielle and I will share the findings here. Mood, of course, medication for opioid use disorder. Now, we know it's well established that methadone and buprenorphine are gold standard treatments for opioid use disorder, contributing not only to patient thriving, but also to reductions in opioid deaths and all-cause mortality. That's established. As we and others have shown, the treatment, though, is mal-distributed and often carceral in orientation, governed by stringent policies that in some cases are contrary to good patient care. And that is also known by the treatment providers themselves, and they struggle with the same liquid handcuffs, if you will, in the case of methadone. So enter MAPI, our study, Mood Access Policy Impact. This is a study to examine the impact of federal regulatory flexibilities, this is DEA, SAMHSA, and CMS, that were applied in March 2020 on access to methadone and buprenorphine during COVID. Now, the federal policy intent, as you might know, was to ensure or even increase access to treatment while reducing COVID exposure. Federal flexibilities allowed several service accommodations, you're going to hear that term periodically, such as telehealth for buprenorphine induction, increased multi-day dosing of 14 or 28 days for unstable and stable patients respectively, license reciprocity, home medications delivery, and off-site dispensing. Now, you've all probably spoken about this as a SATRN group, so you also know that these flexibilities were recommended and so therefore optional and deemed at the time temporary, though we're hearing some discussion about maybe carrying them on, but we just don't quite know yet. Now, in March of 2020, I was approached by 2 harm reduction community leaders in 2 states, Arizona and Indiana, to study the impact of these changes on treatment access. And together, we, along with Danielle Russell, planned the study focused here and shown here. We created and engaged a transdisciplinary group of people across the state who are both mood providers and patients, as well as people with living and lived experience who are not necessarily in any kind of treatment, harm reduction community organizational partners, and university research. And that group is called the DPRAB, and you see that logo up at the top, and that's the Drug Policy Research and Advocacy Board. Now, this study, the MAPI study, is bifocal, and it is designed to look at both what is implemented and what is experienced. So first, we wanted to understand policy experience. Did patients experience the accommodations? And what was their COVID risk? Why do we care about that? We care about that because it's a policy priority at the administration level, both last administration and current. Now, secondly, we wanted to know about provider implementation. We won't report that here. We have a study that's under review right now. We're happy to share it once it's published. But the question we asked there was who was implementing which of the accommodations over a 3 set time period. So before COVID, during Arizona's shutdown, and at the time of the survey or current, which was between 16 and 24 months after the shutdown. So these findings are currently, as I said, in review. We also wanted to get a sense of feasibility and acceptability using the Consolidated Framework for Implementation Research, or CFR, as you probably are aware. And I would just say that this study would position us again to apply for larger grants that would measure policy impact, not just here in Arizona, but elsewhere. We have, through this study, validated an instrument called the MAPI, which would allow us to inform policy partners relative to accommodations, relevant accommodations implemented by treatment setting. Again, we'll share that later. So today we're going to focus on the first of this bifocal focus, and that's the policy experience. Danielle.
Yes, so the manuscript that Beth has added the link into the chat here will describe our method more fully. So there's a lot of info here, especially on the left of the slide. So if you want to see more closely, to look at that, because it's a lot of, describing our sample demographics, please feel free to open the link there and check it out more closely if you would like. But so essentially we hired, trained, and supported interviewers with lived and living experience using illicit drugs, and also using ORT or OST, so methadone or buprenorphine themselves, to conduct 1-hour face-to-face interviews with people who have been or were currently on methadone or buprenorphine at some point during COVID. And I know it's becoming a little harder to define when COVID is, but we define that period as being from January 1st, 2020 to March 31st, 2021 for our study. And the interview guide measured several key issues, including time spent in methadone and or bup treatment, individuals' risk for severe COVID health outcomes using the CDC's own definition, and then also asking about additional health outcomes known to be associated with drug use, such as bloodborne infections, skin and soft tissue infections. Sorry, my notes went a little wonky there. Oh, and then and we measured 6 of these, like the federal regulatory shifts during COVID that Beth mentioned. So we measured 6 of those. That included the telehealth allowance, increased take-home dosage allowance, decreased urine drug screens, and a few others such as curbside dosing, which were, you know, some of the larger accommodations that were allowed during COVID. So we can go to the next slide.
And what I'll share what we learned in a moment, but what I want to share with you is that the DPRAB had a lot of input into what we measured, into instruments. So while we came up with the bifocal methodology initially, the DPRAB became highly involved in how that looked and how it felt and what we asked, and we made changes to our research methodology as a result. And that is part of that CBPAR component, but it's also good implementation science as well, because we had mood providers indicating what should be asked as well. And that was very, very helpful. So from this first focal area, we not only learned that not much had changed for patients relative to the experienced accommodations during COVID, but we also understood that those at high risk for COVID, and that was 40.5% of the cohort per CDC definition, was at risk for COVID here. And the other piece of this, if we added mental health outcomes, so depression, schizophrenia, anxiety, as was suggested by Vaya and colleagues in a 2021 Lancet piece, 68% of the sample would have been at risk for COVID. So we use CDC's definition for a little more conservative approach, but we want to note here that we really had a cohort that had some risk for COVID. And we also asked if people if they could wave a magic wand, how would they improve their treatment? And so they definitely wanted changes, and they overwhelmingly said multi-day dosing in order to stop the life interruptions of the daily clinic visit. So please see the manuscript to hear the voices around this change and around some of the issues and difficulties with the current structure of treatment. We do report these voices as well. I want also to note that as a CBPAR-oriented study, we asked members of the DPRAB to identify capacities that they wanted to develop in the course of working together. All agreed that interview experience was critical and that interviews with patients should be conducted with people who have lived experience. And that was terrific because there was a trust issue and we wanted to make sure that there was safety in the process of the research. So we recruited people with lived experience, trained them, paid them, supported them during the interview period. This, of course, is described at length in the manuscript. But in thinking about these kinds of studies, so backing up a little bit and saying, what is the impact of doing this kind of work? I would suggest to you there are micro, meso, and macro level impacts so far that we've even witnessed in this one study. And at the micro level, experiences included interviewers, field interviewers, getting real jobs out of this experience. 3 people got real jobs. And I mean, when I mean by real, I mean they were moving from a service job or unemployment to a job they could hold with benefits and with good pay in a field they wanted. And one person even got, so a 4th person even got a job promotion. And these things are very important because then people didn't have to hide their experience, but they could actually say, no, I was a field interviewer for this study, which was a policy impact study, et cetera. So real lived experience turned into job experience, turned into job outcomes. One interviewer received a promotion, as I mentioned, and almost all interviewers opted to publish with us and present the findings to the DPRAB. So at the meso level, there were professional networks developed in the course of the DPRAB functioning, whereby people with lived experience began to network with providers and vice versa. But as we'll talk later, if we have our discussion, time in the discussion, there are power dynamics that we want to manage through. So Danielle and I are designing, hopefully for her postdoc, if she decides to stick with me, trauma-informed community-based participatory and action research models so that we could actually allow for space for trauma-informed planning. But at the meso level, we did see networks and communication networks developed, and it was exceedingly fruitful when it came to discussing the translation of findings. And finally, at macro level, our study findings were quite different from other extant findings published or studies published that said basically to point, patients in fact did receive accommodations or providers implemented them. And we think the difference is for a variety of reasons. One is ours was the only study planned and conducted by people with lived experience so far, at least reported in the literature. that the second reason was that the sample was very large for a qualitative study, also statewide, English and Spanish bilingual. And we learned when comparing two important questions, so the magic wand question that I mentioned before, to the second question, what can your treatment provider improve? We saw a real discontinuity in those two answer areas. And after discussion with the interviewers and people with lived experience on the DPREB, we learned, frankly, that there was a huge fear of losing treatment, which likely kept people away from critiquing their providers. And this is kind of a devil you know thing, which helps us understand, or at least surmise, that maybe what's happening in some of the other smaller studies that were published on the accommodations, that in fact people would say, oh yeah, generally things are good and working well. And so we want to watch that in our own work to try to understand what's really happening in these areas. Danielle.
I'll just add really quick to the last slide, Beth, especially including people with, lived in living experience in all parts of the research process. I think for that first, check mark there about telehealth, even knowing to ask the questions differently, because people who were on methadone and buprenorphine knew that yes, they got telehealth, but it was so that their providers could stay home in the safety and comfort of their homes while they continued to come into crowded clinics. So knowing to ask differently, not just, did you get telehealth? It provides that nuance and context that I think is offers like more richness and depth to the information that you're seeing. So just wanted to kind of emphasize the value of including community into the research process there. But
yeah, and also I would add to this note about telehealth. So you all probably know that the state actually passed legislation to assure parity for telehealth and clinic visits, and that is a huge contribution to this effort, which makes us think that, okay, as we look at telehealth, and it was reported most frequently, it's likely not because of the federal change, probably because of the state change, which tells us the importance of the state policy process in this process. Go ahead, Danielle, sorry.
Yeah, no, excuse me. So after considering the interview data and offering interpretations, the DPRAB and interviewer cohort also met to identify key recommendations and strategies based on the study findings. So the next 3 slides identify and describe these recommendations. The first recommendation was to normalize methadone. Clearly, the disparate regulatory structures produce very different patient experiences during COVID. The second was to assure patient-centered and empowered care. There were several related strategies. Some are listed here. We'll submit a HEAL proposal for the IMPACT program to develop and test a patient-empowered methadone treatment process using a trauma-informed planning process in Arizona, followed by a trial in Arizona and Indiana in 4 methadone clinics, so 2 rural and 2 urban. And I think that's it for that slide.
The third was evidence-based care. It became patently clear to the DPRAB that treatment needed to be grounded in evidence, and that national and state minimum level standards were required. Now, you might be saying, if you're treatment provider now, you might be saying, well, yeah, but that's not everyone's experience across the state. It totally might be yours, but it's not everyone's. And so that minimum level standards were important to the DPRAB to establish. A number of patients sought to taper off methadone specifically and were refused guidance by their providers. And this was disconcerting at best and, of course, criminal at worst. We would never, of course, expect a diabetes patient to self-determine their insulin levels after seeking clinical guidance, but this was really a repeated experience in the midst of treatment. And the tapering had less to do with stigma about methadone, although there was a little evidence of that, self-stigma and so on, which is more about the social stigma around methadone treatment, but also that they wanted to get away from this daily chaining to the clinic so that they could take their kid to school, they could get a job, et cetera, et cetera. And those things were very, very important, trying to figure out how to balance one's life in the midst of this setup. Urine screens appeared to be used also as a billing benefit for clinics versus as a medical or regulatory requirement. And this again gets to evidence-based care, what's required and what's important. Danielle.
Yeah. So in our study and so many others, structural issues continue to impact patient stability. This includes transportation, which for our study was a huge issue. And initially we hadn't even asked directly about transportation. It just came up, you know, people were volunteering to talk about the transportation to the clinic. You know, one being that, you know, traveling every single day before work, you know, to and from a clinic was such a barrier to living a normal, healthy life. It was impacting people's decisions about treatment and their health. And then instead of offering the, you know, increasing combinations that the federal regulatory shifts allowed, the clinics instead offer this awful transport service that people were, you know, very eager to tell us how much they did not like VEO. Well, not, you know, in the interviews and volunteer how much they really disliked using it. It doesn't show up, you know, it would leave them waiting. Then they're stuck at the clinic. You're not allowed to loiter at the clinic, but you have to wait for your ride. So it was just pretty awful and all linked to that, you know, structural issues and not, you know, using the accommodations that were allowed, like the increased take-home doses. And then the second area was to assure treatment access equity, especially for rural and unhoused communities. So yeah, there was you know, there's a lot of room to increase field prescribing for rural and unhoused communities. And then also, you know, there's some changes allowed to mobile mood provision as well. So yeah.
So we're going to pause here and have some Q&A. I know you'll read the articles and the slides we've provided through Lonnie too. So we didn't want to read the slides because you're all brilliant and there's just no need to do that. But we wanted to have a chance to talk about what you want to talk about, and then really just puzzle together about how can we all engage the community in research to inform treatment improvements or policy in Arizona specifically. And of course, my contact information is here, and Danielle too, that you know. So we're going to pause right now for some Q&A and discussion and look forward to hearing your thoughts about this. And thanks, by the way, Danielle.
Thank you so much, you two. Yeah, what kind of horrifying what you found, but really, really important. So yes, open for questions. Please just jump on in, or if someone's speaking and you want to get in the queue, pop a hand up. So I'll just, while we wait, I'm sure people are thinking, well, while we wait, the thing that I couldn't help thinking was, why the discrepancy in what could have been happening given the changes in regulations and what these patients were actually experiencing? Yeah, it would be great to hear from you. Robert Cherrick just dropped a note in the chat, and it would be great to hear from your perspective on this too, because clearly there was a divergence in what should have been happening and what actually was. And, you know, your data really speak to the patient perspective on this, but, you know, what could have made that changed or flipped that switch from the provider perspective?
Well, I know that, I'll jump in really quick. I know that what Nick Stavros said, as far as we were seeing a lot of people volunteer information about having stuff like accommodations like the take homes rescinded already. And that's something we didn't ask either. They just volunteered like, yeah, well, I did have it, but they already took it away. And then Nick Stavros said that there's no, like the clinic lost money when they did increase take homes. So there was no way for the clinic to, I guess, recoup their financial loss. So yeah, a lot of what we're seeing is because this is a business model. You know, it's a business, not just a resource.
Which, I mean, the sad fact is that's the way healthcare is delivered in the United States generally. I put in the chat that 60% of our cohort actually volunteered this, which is, like with transportation, like super notable because we're not asking, and yet they really did volunteer this. So it's like, whoa. At the same time too, and again, this isn't published yet, but I'll share with you, of the accommodation. So we studied the accommodations in 3 different time periods by setting, because we really think that matters. And not all accommodations are appropriate to setting. So bupe providers have certain accommodations, methadone providers others, because of the regulatory discrepancies too, And so what we found was that methadone clinics for sure had implemented more accommodations at the time of the shutdown, but they regressed and rescinded at a higher rate, 17 percentage point differences than all other settings between that time and the current time of the study, which was 16 to 24 months after the shutdown. So it leads us to believe that the regulatory environment needs to be thoroughly examined so that we can assure what is better care. So the nice thing about the MPAC study that Danielle had mentioned that we'll be applying for is that actually CMS is our partner on that, and we'll be able to build along with the methadone clinic that is going to be our partner. We haven't chosen them yet because they haven't recruited yet, and we'll work on that, Mark Schaefer and I and so on. But the fact of the matter is we'll be able to build it and ask the staff the same question. You go, wave a magic wand, how would this work? And we can ask patients, but not of the clinic, because we want safety. But people who are on methadone, how would you do, if you could wave a magic wand, how would you do this? And then together we would work out essentially a treatment modality that would be regulatorily possible, and also with some goals for patient outcomes and satisfaction and staff implementation, et cetera. And so that's what we're going to do for HEAL. But I mean, it allows us to really step back and say, okay, well, how could we build this car differently? Could we do this differently? Because everybody wants to do stuff differently.
Which is what's happening kind of with COVID generally. It's like, we don't, as a colleague put it, we don't have to build the tracks in the same place. The tracks just blew up, but we can put them someplace new. Thankfully, we have Robert Cherrick here, right, who is from CMS and had some really thoughtful comments in the chat about, the challenge that the clinics were facing in implementing some of these and the need to kind of keep your business open, keep your doors open, and then also some selectivity about which clients would be better able to manage longer dosages, and I don't know how those decisions were made, but Robert, perhaps you could kind of jump in with your thoughts on feasibility and what would it look like to make this work from your perspective.
Yeah. When COVID came out and SAMHSA made their pronouncement, they really didn't give any guidance. It basically said anybody you think is moderately stable can have 14 days, and if they're really stable, even 28 days. But they didn't actually give any guidance as to how to make that determination: who's stable, who's not stable. And compared to the regulations that we otherwise operate under, which are very specific, it was a very wide sort of range that people could implement. And reading in the lay media, not so much in the literature though, there were some clinics that gave basically no extra take homes, and they had I think everybody did newspaper articles with pictures of a clinic that just packed with people right in the middle of COVID. And then there are others reported that they gave everybody 28 days and said, we're closing for 28 days. See you later. For us, it was not a financial decision. It was, we were trying to kind of cut the difference to some extent. So we didn't feel that we could give everybody 28 days or necessarily everybody 14 days. So what we did is we went through all of our patients. So we looked at what is their risk. In other words, if they were to come down with COVID, what would be the risk of getting complications? And then what was their stability? In other words, what was going on as far as the clinic attendance and their treatment plan and their urine drug screens. And then we kind of tried to do our best in terms of figuring out who would benefit from extended take homes. And we did, as I mentioned in the chat, we did manage to decrease our clinic traffic by 40%. At the same time, we spent a lot of time thinking about traffic through the clinic. The idea being that everybody has to come to the clinic sometimes to pick up their doses, whether it's every 14 days, 28 days, or every day, depending upon what's going on with them. And so we wanted to make sure that when people were coming to the clinic, that this wasn't a high risk option. It wasn't a high risk procedure. So people would come in, we'd manage traffic so that people would be waiting outside if they could, that they were spaced out within the clinic. We didn't have big crowds hanging around. And we tried to make it so that, I mean, everybody had to go out at least, as I put in the chat, go to the grocery store and other normal things. We tried to make it not really any higher risk than that. Of course, everybody was wearing masks. We were cleaning the surfaces. We were really working hard to decrease the risk associated with actually coming to the clinic to pick up your doses. Now, it is true that I think, Beth, you mentioned this. We gave additional take homes to patients. However, if they started to show levels of instability, they weren't able to handle those take homes, then those take homes were restricted. So in other words, if someone, we gave them a week's worth, and then 5 days into that, they're gone, well, that person would not be a candidate for giving another week's worth probably, and that they needed a higher structure. And we find that there are a lot of patients in our clinics that do need that higher level of structure in order to maintain that stability.
So
now, having said that, we are strongly in favor of revising the current policies because we think they're way too restrictive. I mean, that someone who describing a case, say the person comes in and they start on methadone, and here's a person who then comes in every day, takes a dose like they're supposed to. Every urine drug screen is normal, and they make every counseling point. They do everything that they're asked, and they still don't get any take-homes for 90 days.
So I'm curious
that is
about
something we're looking into. That is something we're looking into. There has to be kind of, we think there a happier medium.
Yeah,
about how that is done, and balancing that structure versus giving people basically their lives, because that's what the whole idea is. We want people to have their lives normalized, with the appropriate amount of structure, but not so much that it's all liquid handcuffs.
So the goal is very much the same, right? And I think one of the questions that often comes up in this situation from a policy perspective is which is going to produce the better outcomes, right? A really tighter, more narrow, highly prescriptive policy, or a policy that has more flexibility and discretion built into it. And right, on one hand, very tight policies by definition are inflexible, right? And they are less likely to meet the needs of a person or of individuals, or even if they factor in, right, accommodation of people in different situations, there's only so much you can do with regulatory tailoring, right, before the policy itself gets to be completely unwieldy and out of control. But at the other end of the spectrum, when you have a lot of discretion, and it sounds like part of the issue, what I'm hearing you say is that in this case, there was almost so little prescriptiveness and so little guidance about how to use this flexibility that everyone sort of had to figure it out for themselves. That often doesn't go well too. It's an opportunity for bias to creep in, right? And I'm not saying that this is what happened in your case, but just in general, when you have that level of flexibility and discretionary implementation, bias is more likely to creep in under those circumstances, right? You have different providers with different levels of expertise making different choices. And so from a patient standpoint, that discretionary flexibility can start to feel really haphazard and unfair. And that's, I saw, Danielle, I saw your comments in the chat that were suggesting that was part of what you were experiencing, like different providers, individuals have different levels of comfort and different ways they're going to handle that. So where's the sweet spot from a policy perspective when you have those two poles and limitations of each of those poles? Danielle?
Yeah, I mean, I agree. There needs to be that happy medium, and I think the appropriate amount of structure coming from CSAT and from SAMHSA in terms of giving guidance in terms of what we should all be doing. So there's some sort of uniformity, so that both OTPs and patients can kind of know what to expect.
Well, and the nice thing about research. Oh, sorry, Danielle, go ahead.
I was just going to say, I was just in Australia, and then I was in Scotland in the UK right after that. And I went with people to pick up their methadone in both countries. And when I was in Australia, I went with one of the women from the drug user union there, and she went and picked it up at a pharmacy. It was like a better than average pharmacy visit here if I were to get antibiotics or something. It like was very almost emotional to watch, because just based on what I've experienced here, which I mean, I don't know that I could call it anything other than abusive, what I've experienced here accessing methadone. So it's like amazing. Like it can be done other ways. Like it's totally possible. Like other places do it in ways that don't hurt people and is accessible. And then even in Scotland, you know, going with friends, it's like I went to the NHS place where they go get, you know, some of them were getting like that Buvidal stuff, some were getting methadone, some were getting Suboxone, and it wasn't like they were able to make that decision independent of financial kind of pressures, stigma pressures, although there was still some stigma and like preference towards Bupe because 12-step stuff is kind of becoming more insidious over there. But yeah, so I mean, it's like it is possible to do things without hurting people. And I think here it's like the clinical setting, like keeping it siloed in the clinic is like a, you know, a remnant of like historical, you know, racism around methadone. So I mean, I think, you know, we could step away from this. There's nothing stopping us. It's just, you know, the will to do it and the disenfranchised population that is served. There's not. I think that's what it is. It's like a disenfranchised client population that is like scared to push. Even when we saw in the study, I would listen to interviews where people were crying, talked about suicide attempts after their experience at these clinics. And then when asked, what would you change? They say nothing, they're doing a great job. You know, you have to deal with horrible people like us. And it's like, so the disconnect there, when you have a client population that won't advocate for themselves, that feels like they don't deserve better. I think that's part of the problem as well, is there's not a lot of, yeah, it's just, yeah. So I mean, it's multi-pronged, I guess is what I'm saying.
I really appreciate that, Danielle. And you know, the thing that it raised for us in the DPRAB and in the research team writ large is that there are two issues. To your point, Lonnie, any policy change is going to have to be tested out, especially in such highly regulatory scenarios. And so even as we talk with our partners at CMS to find out, you know, what could we build that might be different, that might move us a little further, it's going to have to be within the regulatory space. Now, you know, we did this with syringe access in the 80s and early 90s, and same anonymous testing for HIV, et cetera. So I know it's possible, and it's not, you can't go from 0 to 60 immediately. The other question gets back to what we were asking the group is, how do we involve communities in the development of these policy changes or practice changes? Because the education in the DPRAB was really, really helpful, even if it was still fraught in ways that we were just talking as a research team before this meeting, how we can improve these dynamics from a trauma-informed perspective, and how we can handle the various you know, spaces people come from. But the other thing I would say is that what our team ended up asking, and we're asking this also in the provider paper, is that the country itself has not decided what the goal is for treatment. And is it abstinence completely off of every single substance? Is it access to safe drug supply? In the case of fentanyl, for example, you know, as we see fentanyl, is it something else? What is it? And we don't know. And so even our clinical providers, as Robert had said, you know, we're all we're in the catcher's mitt. We got the catcher's mitt. And so the question is, you know, until we decide what that goal is as a country, and then and really, really think then about our policies and what that might look like, you know, that's really the root cause of some of these problems, and the history and the social construction of all these things that Danielle is giving voice to from the interview data. And it was really intense data.
I think that's an important point. SAMHSA has subsequently given out a bit more guidance. They have defined what they had meant by somewhat stable and stable. But interestingly enough, if you take a close look at those criteria, and they're fairly detailed, they are abstinence-based. In other words, they are assuming that the goal of treatment is abstinence from all other drugs, whether it be other opioids or some other drug, maybe excluding marijuana. But so that I think is still kind of an important issue. And, I agree absolutely with you, Danielle, that there is a lot of improvement that can be made. I think one of the things we need to think about, it's come up a couple of times, and I think it's important to address, financial incentives can create very aberrant behavior. And whatever we end up doing in terms of changing the system, we don't want to dismantle 1,600 OTPs across the country. And then we have a bunch of patients who have no access to treatment. So I think I agree with you, Beth, in terms of testing it out, making sure that it's going to work, and also working with the people who are doing it so that they can continue to do it from a financial point of view, and there aren't perverse financial incentives to do the wrong thing.
Yeah, so with the Urban Survivors Union, which is the National Drug User Union, has a methadone reform team. And, one of the things that we, increasingly run into is there's so much fear because, this is the drugs are a life-sustaining resource. And so anything that seems like we would be attacking the clinic is an attack on someone's stability and what they need to retain their, all their stability. So it's very scary, especially if someone thinks you're coming at this resource, albeit maybe something that does not serve them well, but it's like Beth said, the devil, it's what you have and it's sustaining you now. And you can juggle the problems that it throws at you, at least for the people that it is working for. Many people it doesn't. And that's also, I don't think, quantified as well. But yeah, so it needs to be more about not dismantling the clinics, but offering other options. Because right now there are none. It's like a legal cartel just siloed within the OTP clinical setting. And so if it just needs to be other options, like leave the clinics up, works for some people even like it. So for the people that like that, yeah, definitely leave, and I think that's definitely the stance of the, USU's methadone reform team as well as, no one wants to dismantle the clinics. We just want increased accessibility, increased options. So, and people have to,
yeah, for sure.
Ultimately, just more choices.
But we've also seen this whole NIMBY thing, like where there's need for methadone, these neighborhoods just raise up against the clinic. And I think that's important too. And it has nothing to do with the issues the clinical issues we raised in the past in this study, but there is this social bias against methadone. And again, it gets back to, we got to really address that because it's life-saving. So is bup, but bup doesn't work for everybody. And so, what are the options that we want to give people to living their best lives and back to the goal here. So yeah. But so much to talk about. We could talk about it for years. Are there other questions that you guys wanted to ask? Because I'm so sorry if we took too much time, but I really appreciate the conversation. Certainly, Dr. Sher, your views always certainly matter. Mark, I didn't know you're on the call, man.
I'm so sorry. I jumped on a little bit late.
Oh, okay. What were you talking behind your back?
Good.
Yeah, I also point out, by the way, Wisconsin has, as a state, has a lot of state regulations. And because of that, 95% of our patients in Wisconsin are on daily dosing. That is very different.
Yeah, because you couldn't do any of the flexibility.
We have no flexibility. If someone tests positive for fentanyl on one urine drug screen, even if they had monthlies, we're required to take them down to dailies. So it's not just the federal, it's states as well that have a lot of these regulations that need to be torn down.
There were several states that actually pulled back the regulations, including Ohio and some of those where it did create a little bit of fear for some of like, well, okay, these are still here, but are they pulling them back? What do we have to have a plan? North Dakota did the same, but the state was much more helpful in saying, look, we're looking at about 3 months, 6 months. Let's start working on plans. Let's talk about different individuals. But then some states have left them in, and we still had a reduction of them. So I think there's, as everyone said, there's a lot of work to be done, and the person's voice needs to be in there because that wasn't in any of those discussions.
Yeah, it was interesting too. When I was in Sydney, they mentioned their mortality rate there and for overdose, and it was like for the month, it was like what we had for I guess for the entire state. I need to ask them for the data from that presentation, because it was like when you compare the overdose rates for here in the States, it's so much greater, like staggeringly greater than places like Australia. And I wonder how much of it is that treatment is just so much more accessible, like effective treatment. Whereas here it's like, very.
Yeah, and that's a good point. And I don't know offhand the data, but in many of the states that have, I think, the biggest barriers also have the biggest problem. Interestingly enough, when we look at our data in Wisconsin, our retention rates in Wisconsin, even though they're an outlier from our take homes, are not actually lower than the rest of our states, which is interesting. My interpretation of that is that people in Wisconsin fairly quickly learn that if you come to an OTP, you probably won't get a take homes. So they just don't bother coming if that's not going to work for them. So to me, it's a barrier for them coming in, potentially as well as staying in treatment.
Well, especially too I emphasize this to anyone that I'm in front of, with the prices of fentanyl. Like, I'm hearing people say it's 20 cents a pill coming out of Nogales. So it's so cheap that even me hearing that on a bad day at the clinic, I'm almost like, wow, I could sustain a habit for pennies. And here I am torturing myself and compromising my values in many ways to sustain treatment at the clinic. Because the way that I'm treated there is not a way that I would ever allow myself to be treated anywhere else in my life. So it's like, you're weighing out. And if I'm rationalizing and weighing this out, I'm sure there's so many people that are also thinking, like, why would you go into treatment when it's so incredibly cheap? And I think it's only going to get worse if that's the prices we're seeing here on the border. But my doomsday prediction.
Well, this has been such an incredibly valuable conversation. I think we've had some trainees on the call, and I think for them it was really, it's really been eye-opening to hear both the presentation and then the discussion around the practicalities of these issues, right? And how you deal with the challenge of doing research and then implementing research in a way that will provide really strong evidence for the very difficult practical decisions that need to be made.